Okay, so a little bit of background in terms of, and I know that there are some people who are in Africa. The presentation is focusing a lot on Europe, but migrants in Europe, and that doesn't mean it's not relevant to the work you're doing. I think there's insights and there's shared learning that you can attain from this. So I thought I'd just kind of set the scene of what the landscape looks like in Europe currently. And currently we have over 2.1 people living with HIV, and estimated people within Europe, EU, is about 792. What is very surprising is that more than half of the EU population that are accessing care are of migrant descent, 56%, and more than half of the people diagnosed with HIV in 2025 so far. This, I think it should be 2024. I made a mistake there. In 2024 is 58%, so it's way more than half of new diagnoses for HIV are diagnosed late in Europe, and that is quite saddening. And that compounds a lot of what all of you have shared in terms of the challenges you're finding in your work. What is also known is a significant proportion of migrants acquire HIV in their country, in Europe, not necessarily in the country where they were born from. It's mostly in transition to where they are moving to. And, I know this is not new to you because many of you have highlighted this. There's a low uptake in prevention of HIV, and whether we are talking about condoms or PrEP or testing, there is really a low uptake from migrants. And that kind of just sets the scene in terms of how we are in currently faring on. This is, again, just an insight in terms of knowing by region where we are at. And this is where where I was talking about the consistency in terms of men who have sex with men are majority, but then there is also a large number of heterosexual men and women. Looking at the different regions, the Western Europe, Central Europe, and Eastern Europe, and looking at the consistency in terms of diagnosis. We also have to note that a lot of the diagnosis is through through sex. It's only a small proportion that is through injecting of drugs. And again, when we are looking at diagnosis of people born abroad, meaning out of the country where they're at, again, those percentages are quite high. When we look at Western Europe, Central Europe, and Eastern Europe as well. If we move to the next slide, again, we're looking at new diagnosis and by transmission routes. For migrants, again, this is between 2014 and 2023. We are seeing that the number of diagnosis around migrants. Sorry, I am trying to move my screen so that I can trying to move you to one side. So heterosexuals born abroad in where they're not staying has increased compared to those born in the country they are at. And again, this is referring to migrants and the increase. There was a small decrease, but that was during the COVID time because, again, there was less testing. But then after that, there's a sharp increase, and that seems to still be increasing. It hasn't plateaued. If again, we're looking at new diagnosis by route of transmission and migrant status, again, we see that for sex between men born in the reporting country is still much higher, but then those again with born from a foreign country is also steadily increasing as well. And this is with men who have sex with men. So I'm just trying to set the scene, and you will get these slides and be able to digest a lot of these statistics. Again, when we are looking at the diagnosis of migrants in different countries, and some of you will see your countries represented here, it is still a huge number of sub-Saharan migrants who are then coming and being diagnosed. Then we also do have a lot of migrants in Central and Eastern Europe, as well as some other areas, Eastern Europe, because again of the war. That's why we have a lot of the migrants as well. But that's just giving you a snapshot that, again, 56% of the migrants who have been born out of that country of recording are the ones who are diagnosed with HIV, again, which is more than half. Again, if we're looking at it, and this is men who have sex with men from who are also migrants, we are looking at based on unknown transmission, but again, looking at the concentration in EU and in other, there's more MSM with diagnosed HIV who are migrants compared to those who are not migrants. And we, one of you shared you take PrEP to migrants, Black migrants, because they have not shared their status, they haven't come out. So again, we have to acknowledge that some of these figures may not be accurate because of the stigma and all these other barriers that are around this kind of collecting these statistics. So I had prepared this slide, but because I've heard from all of you, I'm assuming that everybody really knows what HIV is and how it's transmitted and the difference between HIV and AIDS. So I'm not going to spend a lot of time. I'm not going to actually spend any time on this. I'm assuming all of you know what this is. You will get these slides, and if you need to go to ask me any questions to this effect, they will share my contact details and we can have a discussion. Maybe what I will dwell a little bit on is HIV transmission, because of the myths that are there in different communities around how one can acquire HIV. We know that so many people, especially from Africa, have different myths and misconceptions. There's a lot of misinformation around how they contract HIV, and people associate it with punishment, people associate it with being cursed or all sorts of funny things. But it's important to highlight when you're teaching people, when you're doing outreach, that HIV transmission happens with the quantity, the quality, and the route. The quantity is HIV is in bodily fluids, and these are normally blood, semen, vaginal fluids, breast milk, and anal mucus. That's where the HIV is transmitted through. The quality is the type of quantity, the type of virus someone has. If a virus is strong, the number of copies in a sample fluid, that exacerbates the transmission. If the quantity of the virus in the body is not a lot, transmission will not happen as easily. And that's where we get the U equals U, which we'll talk about later, but meaning that if they're able to control the amount of virus in your body, you're not able to pass HIV on to somebody else. And I understand that some people may know this, some people may not know this, but it's one of the new advancements that we now know about HIV as well. So the quantity, when someone has a high viral load, what they call a high viral load with a lot of HIV in their blood, they are more able to transmit HIV to another person. When they have a controlled viral load, they are able not to pass HIV on to somebody. And people can start treatment and get to a level of having controlled viral load even within a month. So it's also important to tell people that earlier they start treatment, the easier it is for them to have a controlled viral load. And that once they have a controlled viral load, it means that their body is less damaged, it's able to function better, and gradually able to function as good as somebody without HIV. And then the route of transmission normally is through blood, through sex, or through sharing of needles, or through blood transfusion for countries where that is still a practice and they don't screen the blood. But these have to be at optimum for transmission to occur. It's not around touching, kissing, sharing utensils, looking after somebody with HIV. All these do not transmit HIV, and it's important that we highlight that.
We have a question in the chat that
Yeah.
from Laura. There is a debate about HIV transmission through breast milk, and some doctors think it might be safe to give breast milk if person is on medication. What do you think about that?
So guidelines in the UK and in some European countries allow for you to breastfeed if you're on treatment and you're undetectable. The guidelines have changed. I know that in some other countries those guidelines haven't changed, but studies have been done and found that it is okay to breastfeed if you're on treatment and you're undetectable. It is okay and safe for you to breastfeed. What I would suggest is you follow the guidelines of the country where you're at. But in the UK, you can breastfeed. If you choose to, you can breastfeed. I hope that's answered the question. Okay, so this is an illustration I always use when I'm training, especially people who are new to the subject, to understand CD4 and viral load and how that plays a role. And again, this can be useful when you're educating in the community, and to understand the CD4 is your immune system, your T4 cells, how your body is able to defend itself against infections. And yet the viral load is how much of the HIV virus you have in your blood. And if you're looking at it like a seesaw or a weighing scale, the more viral load you have, the more protection you have in your body. That means your immune system is working well. That means you're not likely to get ill. The more virus you have in your body means your immune system is down, you're not able to protect yourself, and therefore you're open to opportunic illnesses. And gradually, if untreated, you'll develop AIDS. That's kind of a simple way of explaining it. And I use that diagram to say you should always make sure someone, advocate for medication, because medication will reduce the viral load. And when it reduces the viral load, your CD4 count, your body's defense increases. And once that's working well, you live a healthy, normal life with minimum health issues because your immune system is working well. The problem comes when you have a huge viral load, when you're not adhering to your medication. And for so many reasons with the migrant populations, this happens. We all are working with them. There are so many other issues that take priority over treatment, but for them to understand, if they prioritize treatment, it means their body will function well and will be able to support them. But if they don't adhere to their medication, the viral load takes control. And when it takes control, it compromises their immune system, and gradually they fall ill and get sometimes irreversible changes to their life. They could lose mobility, they could lose eyesight, they could have various life-changing issues. So it's around prioritizing treatment so that they can live and have a better quality of life. So I wanted us to have a group discussion here And maybe because we are very many and there is little time, I will only ask for 3 volunteers to share how you identify, what is your experience around the populations you're working with in identifying prevention needs in those populations. And can we have 3 volunteers? I know Luciano said they're already an expert. It's only around PrEP where they're not yet. But if you want to offer an insight, thank you. That would be welcome.
Okay, I think that to have a real mobile would be very good to meet people on the street. The major problem in Catania is people living on the road without a shelter. So this is a real problem because we don't have a real dormitory. So it's difficult when they have more than one pathology to treat them or to help them in taking tablets. We have 3 cultural mediators and some volunteers that 3 times a week they go around to meet these people. It's not a mobile, but sometimes it's even better because the meeting is more free, the relationship is easier to start. The other problem is that we don't have a low threshold services for STI. You can't, if you have people who are in needs of emergency for treatment or for diagnostic tools, we can do that. We need to book for an appointment 2 days, and after sometimes it's difficult to find the person to accompany the person to the hospital or whatever. The only low threshold service is our, but we do only HIV and hepatitis C test, and but we can prescribe medication, and that is very good. So I think that a mobile with trained people and with the peer people, so people from the same country, that is would be a very good solution. But the problem is that we don't have any organization funded or any foundation that give money for this kind of services. But in any case, at the moment, we are able to face the situation. The problem now is with people from East, Sri Lanka, Pakistan, Afghanistan, because it's difficult to find a cultural mediator. They have a culture very different than ours. Even from sub-Saharan Africa is easier. And these people, they are not always poor. They come and they have money to start a new profession, so they are not really easy to
engage.
meet. The work is easier with the young African people, from sub-Saharan, and with them another option is to prepare. We say cooperative. I don't know how to translate, but the work cooperative, to start with them agriculture or even other, and this is a good way also to meet and to make prevention. But we are not able to speak about come si dice quella dei farmaci, prevention through treatment.
Okay.
It's difficult.
Thank you.
You're welcome.
I remember you said I remember she said she's in Ireland, but I've forgotten your name.
My name is Anne.
Anne, thank you.
I wanted to share that with us before we engage with the community, before we kind of like go into the community and do the prevention piece. We do an education piece first. So we do the HIV education, how HIV transmitted, everything about HIV. and we leave it with the community for about maybe 2 to 3 weeks for them to process, for them to reflect. And then after that, then we go back, we book an appointment to say we will be on site or we will be coming to your community, after 3 weeks to come and do testing. We give them enough time, like 3 weeks, in order for them to just, reflect and process, because the main message that we would be giving is, when last did you have unprotected sex, or when last do you think you've been at risk? And when you leave that sentence with them, they take it home and they start thinking, why did she ask that? If I have, or if I engage in unprotected sex, that means I need to get tested. Otherwise I won't know. And the 3 tests that we do are non-symptomatic. They are HIV, syphilis, and hepatitis C. And the moment you kind of like talk about them, then there is need and urge for them to come and do the testing. And the population that we actually engage with, our migrant community, we engage with sex workers. We also go to drug and alcohol rehabs. And the moment you go in once, that's it. You have them every time they maybe every 3 to 6 months, they will actually be calling themselves to say, can you come and do testing for us? So we also have specific times in the year where we go to universities and third level institutions. And it's the time of the RAG week or SHAG week, or the time that students are just coming in to coming into the university. Yeah. It's a strange word, but that's what they call it, the Shag Week. So after that week, after the Rag Shag Week, we give them about 2 weeks, and then we actually go to the universities, and that's where we distribute the SH24s. But with the rapid, we use it for migrants. We use it for sex workers, and also we use it for people that are using substance. We also are involved in, we also are connected to churches or faith-based kind of churches, where they are the ones who talk to their congregation, and every now and then they invite us to go to the church, and they might give us a small little space, very private and confidential, for us to either hand out SH24s or to do testing. And apart from that, I think the other way is that they will actually contact either me or they'll contact the reception in order for us to meet them where they are. So I do go to wherever anybody is. I have 37 volunteers from the community, and most of them are from Sub-Sahara Africa, who take the message into their own communities. So it's very kind of like a two-way thing, whereby the volunteer will go to their own community and pass on the message about testing, about HIV prevention, about everything. We train them 2 days, and then after that, we send them to the community. So it's working. And so far, I think the project is 1.5 years old, and we have done almost 2,000 tests, as in rapid tests. Thank you.
Thank you. Thank you, Anne. Thank you. And I will call you Shag Week from now on. Thank you. Luciano, did you want to add something quickly before we move on?
Yes, I forgot to tell that, the young people from Sub-Saharan Africa now, they are enrolled in selling drugs. It is becoming like the 90s, when, the Italians, they were selling heroin, and after they become HIV positive. Now something like that is happening, like they start to sell marijuana, but after they sell crack, and after they start to use crack, and heroin is coming back. So when they start to use by blood, so they are now at risk for HIV again.
No, thank you for highlighting that. And that's one of the factors, survival, and survival leads them to risky behaviors out of that. Thank you. Very quickly, I think it's Georgina or George, sorry.
Yes, so it's George. So, for example, in Barcelona, what we do with African migrants community, especially LGBTI and MSM communities, what we do is like we actually try to get like a focus group discussion, more especially with asylum seekers and also immigrants, you know, in actually ad hoc meetings within communities. And then we actually try to give them like a self-administered questionnaires, which they would be able to actually answer the questions. So we actually do it on papers because we found out that most people who actually, most migrants don't have access to phones, internet, and all those things because of the, so we actually do it on paper. And then we'll give them referral, you know, based on the communities where they live. So when we go to a community, like for example, like in the center of Barcelona, we have the checkpoint program, which is a government program, and then we have the HIV PrEP points program, which is an LGBTI focused, and it's run and handled by LGBTI people within that centers. So we normally tell them that they can actually drop in. So at the end of the questionnaires, they will have the addresses and things like that. And believe you me, a lot of people do drop in the center at their own time and not giving them like pressure to actually go get tested. So that's the strategy that we use to identify the prevention needs within the African migrant population in Barcelona. Thanks.
Thank you, George, for sharing that, because you're doing something similar to what Anne said, and Luciano has shared that, where you're going to the people, you're not waiting for the people to come to you, you go. And in your case, you're even asking them to have a self-assessment of what their needs are, and then you design your service according to their needs. So I'm hoping that's helped other, sorry, we don't have enough time. Okay, Yvonne, otherwise we're not gonna, but I'll let you speak. Go on and share, Yvonne.
Yeah, just to add on what Anne has said about the community that we work with. So for myself, I work with Somali women, and it's a difficult group to work with because they're very closed off because of their religion. So for them, when we do other stuff that needs support and stuff, it's very hard for them to come in. So usually I meet them at a place where they feel comfortable. But when we do like conference, we do conference every year for people living with HIV, and then we have consultants and doctors that come in, and then they will talk about what they need. And then if there's any issues with their medicine or anything that they can speak. But every time we invite them, they don't come. So it's really, really important that to have somebody maybe from Somali speaking in their community that can come and say, hey, can you do this? This is for your own good, and it's also good for your community. But it's so difficult to find that person. That's all.
No, thank you. And that's a very valid point, that the finding the peer navigators or peer champions that can work within the communities where they have shared culture or shared values, shared faith, really, really goes a long way. But it's also advantageous because then you're able to tailor that service specifically to that group. It's very off-putting when a service is not designed for the people you're asking to use that service. So they'll come in and they will go away because they don't feel that it's a service that's been developed for them. A bit like how, I forget, she was the last person who spoke, Lillian, who was saying in Germany, where everyone thinks PrEP is for men who have sex with men because of the way it has been marketed, the images they see. So then it comes back as a product that's not going to support or help other communities because of the way it's been branded. So it's important that the cultural aspects are always taken into consideration. So this is from the few
And I also add that we work in the churches. The program is called Your Health, Your Faith. we work in churches with pastors, and we carry the message of HIV prevention in churches, in African churches. Also there, when you talk about PrEP, you somehow cross the borders.
No, thank you. And thank you for sharing that. Again, it's the going to the community and not expecting the community to come to you, not putting pressure on them. I think Anne shared, let that information sit with them for a bit before you engage. But, you know, we all know, giving the examples that have been shared, that the issues that migrants face around legal status, around being, you know, moving from one place to another, never being in one place, even in, for example, here in the UK, where asylum seekers are housed in hotels and are moved at short or no notice at all to other locations, that disrupts their integration. Then limited access to healthcare in Europe, where there's insurance and you have no papers and you have no insurance, all those become limitations to access. But there's also the issues around stigma from HIV as a subject, whether it's from a culture perspective. Ivona shared about the Somalian community, and there are very many other communities that are very closed around this subject, even when we look at Asian communities, and how stigma plays a huge role in terms of how someone will engage with services, or even when they get a diagnosis, how they perceive themselves because of the stigma that has been carried within a society. Language can also be a huge barrier, especially if you're going to a country where you can't speak the language. Therefore, how are you going to even navigate what you need, or navigate how to get healthcare or the insurance reimbursement policies? It really becomes a minefield. And I think one thing we should not forget about all of this is, with many migrants comes trauma in terms of how they've ended up in the country they're in. Sometimes it's not by choice. Sometimes it's by choice, but there is trauma involved in all of that, trauma involved in the separation with family of the country they came from. So all of those play a huge role. And then cultural norms also play another huge role in terms of what are their norms, what are their cultures around sex, around relationships. There's power dynamics in many cultures for women who have no say in the relationships they hold. There are all those other considerations, and it's a huge ask for you to know everything. But if you're able to work with champions or peer navigators, that gives you an inroad to make sure that you're tailoring those services to the people you're trying to reach, and they're able to resonate. You know, why would they understand that HIV is an issue for them? If you're going through faith and faith is the inroad, then you are tailoring the HIV as part of your health in a faith lens that then is palatable for the faith community you're trying to work with, and that's more effective. And then we also know around the Black market, Luciano noted that, and we know a lot of survival, you know, and sometimes it's not out of choice, where they're leading into practices in order to survive, in order to have food, in order to have a roof over their head. Some of them have debt that they're paying back for the travels that they're making, and that puts them in precarious situations. Both his example of young men who are now selling drugs as a source of income, but to women who then do transactional sex for, whether it's status in immigration status, whether it is a roof over their head, whether it's survival. All of these put them into vulnerabilities to contracting not only HIV, but other STIs as well. So again, when we look at some of the barriers, if you're trying to encourage communities to test, what are the barriers that they will come across in terms of why they feel they shouldn't test? We know some of the things around the stigma around disclosing someone's status, in the criminalization if they then sleep with somebody else and they are sued. There's that fear. There's the lack of confidentiality, and this is both in healthcare settings, in society. What does that mean if somebody's in a refugee camp and everybody gets to know about their status because it has been shared by a professional without their consent? And we've had situations. I'm currently supporting a lady who's in a hotel. She was sharing the room with two other people. One other person went through her bags, found her medication, has put it on their WhatsApp group in the hotel, saying she's put the medication in, saying she's HIV positive. She's getting a lot of abuse. So you have to understand the genuine fears that people face because of either testing or even being diagnosed, and how they're going to survive after a diagnosis. And we know that even with good treatment, an HIV diagnosis is not necessarily a good piece of news. So that also plays a role, but it's also rounded by fear and ignorance, not knowing that it's managed. I think I like the Anne you shared, why would you die from, I think a campaign you did, why would you die from an illness that has treatment? So it's that ignorance to educate communities that there is treatment, people can live well, they can do everything they would like to do if they're on effective treatment. And for those that where we are then trying to talk about prevention, in trying to say there is prevention strategies that are effective. If we're looking at PrEP, that are effective, that we know can help you if you're in a situation where you are really vulnerable to contracting HIV because of your refugee status, your migrant status, you're engaging in risky behavior. And risky is a word that I use subjectively, but if, for example, because you're a migrant, you have no income, you have no accommodation, you are then having transactional sex, and that's putting you in a vulnerable situation. How can we prevent you from contracting HIV instead of labeling or judging you? Those are some of the things that you encourage. And the incentives then, when again you're talking to communities, the idea that you'll have a peace of mind once you know what your HIV status is. If it is negative, then how do you manage to keep it negative? If it's positive, how do you maintain a healthy life living positive on treatment? The different treatment options, you're able to plan for your future in terms of if your result is negative, then that can be a clean slate. You can sell that as a clean slate where people can then say, okay, now I know it's negative, I'll make sure I use either protection, or can I get PrEP, or can I be faithful in one relationship? There are different other strategies that that one can adapt. But then they also can have access to services. I think somebody mentioned earlier around attending clinics for other, so you have not only the HIV screening, but you have syphilis, you have Hep B, Hep C. I think many of you said you combine that with other illnesses, so you can get the support for and access for referrals for that. You also have prolonged life now that you're on treatment, and most importantly, if you're on treatment and you're adhering and you're able to get undetectable levels, you're not able to pass it on. So those are the good things that you can give as incentives to encourage people to test when you're talking in communities around the benefits of knowing what your HIV status is. I had put us to have a break, but I also know that we have just about 35 minutes. So I'm going to skip the break and we'll whiz through if you don't mind. If you do really need to move, you can please just excuse yourself, get your cup of tea or something, coffee or something. So I'm going to talk about prevention, and I know PrEP has come up a lot, but I also want us to remember that there are also different other forms of prevention. And again, when we are looking at migrant populations, they may not have access to PrEP. In some countries, PrEP is not readily available, or there are restrictions in terms of insurance or reimbursement. So there are also other methods of prevention that we should not ignore, that we can also try and educate our communities about. And what we have learned over time is choice is really, really important in terms of prevention, or in terms of health and well-being. Just like we have many options for contraception methods, it's also good to have many options for PrEP prevention, for HIV prevention. So I thought we'd just highlight the different other forms of prevention before we then talk a little bit more about PrEP. And we know that there is treatment as prevention, which spoken about the U equals U, and in a slide I'm going to talk a little bit more about that. And that having an undetectable viral load, meaning you're not able to pass it on. There's condoms and femidoms as well. There is PrEP, which is post-exposure prophylaxis. If somebody has had an encounter and thinks they have acquired HIV, they have a window of 72 hours to get PrEP. However, the earlier they get PrEP, the more effective it will be. So it's important to know all those different strategies. And I just wanted to talk to this image, because the center of everything it's around HIV testing. Even before we talk about PrEP or prevention, somebody needs to know their status. So if we use that as the baseline of where you start in terms of mapping out your work, you're looking at HIV testing or screening, and whether you provide this as a service yourself or you signpost them to health centers. At least that should be your starting point. And then if we look at somebody then being diagnosed, so after they've had their HIV test, it's reactive, they're diagnosed with HIV, we have to make sure we link them into care. And that varies in the different countries, but I believe as the organizations you already have, some of you have shared your referral pathways, your linkage into care. So you make sure you link someone into care. What we have now learned as we try and get to our 2030 goals, that it's also equally important to retain people in care. The UK has learned that there are more people out of care than those undiagnosed with HIV. So it is important that once we have people diagnosed with HIV, they're linked to care and they remain in care, meaning they remain on treatment. And there are many reasons why people drop out of treatment. And when we look at migrant populations, it's even, the issues that affect them are more. So their retention in care is very, very limited. So how do we sustain? How do we maintain? And the last slide we have today is around that support network. So we'll discuss that as well. And then making sure that they remain virally suppressed. So that's the care part of it. Then when we look at prevention, so if someone has done the test and their test is negative, how do we make them understand their vulnerability to contracting HIV? Are they aware about the different options to prevention, and whether it's PrEP, are they aware about PrEP? Do they think this is something that they would benefit from? Are they aware about condoms? Have they used them? Do they use them effectively? Do they know that they're different sizes, or femidom? Do they have access to them? All those kind of questions that you ask. And again, with PrEP, if that's something that they would want, how do you link them into PrEP? For those of you who don't prescribe, I think some of you have said you prescribe PrEP. For those who don't, how do you link them into where they can get it? And how do you support them, especially in the UK and some other countries, it is free, but in some other countries, it's not free. How do you support? Where can they get bursaries to be reimbursed for PrEP? Those are the things you navigate around that. So if we look at treatment as this is not supposed to be treatment as representation, it's as prevention. Sorry, I will change that. And I've shared this a lot. I've never seen that mistake. So it's around what we now know, that somebody on effective treatment, if you remember the balancing scale I showed you earlier. Someone on effective treatment means that they've controlled the virus to a very low point, that it is undetectable, and meaning that the amount of virus they have in their body is very little to pass on to somebody else. In layman's language, that's what it means, that if they have HIV and they are taking treatment, the treatment is able to really suppress the virus to a point that they have very little to damage their own body, first of all, but to also pass on to somebody else. It doesn't cure the virus, and I think someone wanted to know about vaccines and stuff. There is no treatment there's no cure for HIV at the moment. What exists is managing it as a long-term illness with treatment, but there is no cure. There are trials, but at the moment there is no cure. But managing it with the treatment means you become undetectable, and when you become undetectable, it means you cannot transfer HIV, you cannot transmit HIV to another person. This is sexually. This means when you're having sex, unprotected sex, you can have unprotected sex, but not transmit HIV to another person. And these were done in studies between 2014 and 2018 with 126,000 condomless sex interventions or people actions, and through that, where one person was living with HIV and another of the couple did not have HIV, and no HIV was transmitted to the people who did not have HIV, when the ones who in the trial who had HIV were on treatment and undetectable. So we know that it works, and you will see this term, and it's there are other debates around simplifying it that is very clinical, but it means U equals U means undetectable equals untransmittable. There are other campaigns that have been can't pass it on to simplify the same thing. Then if we're looking at barrier methods, there's condoms, there's femidoms, there's dentoderms, and all of these are barrier methods to prevent transmission of or sharing of sexual fluids, this becomes a barrier for sperm or bacterial viruses getting from one person to another. Maybe to highlight for femidoms, it doesnn't stop certain viruses or bacteria because it covers a small part of the vaginal area. Dentoderm is used by men who have sex with men, but again, for people who perform oral sex, it's good for them to know about this, and it can be a protection for some of the viral infections that they can get from oral sex as well. It's also important for your community to know that there are different sizes and types of condoms with different fits, different colors. And I don't know what your access to condoms are, but if you can be able to get condoms that represent the community you're supporting, it's even better. We have found condoms that are black in color or that are kind of darker color, and that means from feedback we had from people using condoms that the bright condoms, there were condoms glow in the dark and all of that, but they felt they were like a sore thumb, so people preferred to have black condoms or near dark condoms so that it did not stand out. They felt more comfortable using that. Yes, Sean, I can take your question.
Sorry, Judy. Wonderful session. Wonderful session. Congratulations. I have some specific question for Judy. This is a question that most of time, some of my youth here in Paris usually ask me. We know that undetectable means that you cannot able to transmit the virus to your partner. But most of time, those youth are asking me, if I meet a friend for the first time, who is a person living with HIV and who is undetectable, how can I know? Which kind of proof can I have if we are ready to have sex, and the person just said that, don't worry, don't use condom. I live with HIV, but I'm undetectable. But how the person will be sure that what the partner saying is true? That is the question that most of the time they ask. Thank you.
Thank you, Jean-Paul. And I think that's a valid question. And I think it's also representative of young people being honest with the realities they face. And my advice would be, if that is a casual partner, you're better off using protection, because you don't know. If it is somebody you're in a relationship with, over time you will know whether they are adhering to their medications. Possibly you go to the consultations together. You're more involved in their life, so you would know. But if it's a casual partner, I think it is safer to take precaution. We also have to be responsible and honest to say that, while somebody on effective treatment would not pass HIV on, they can pass other STIs on. So it's important that they take responsibility for also other aspects of STIs that they may be able to contract if it's a casual partner. I hope that answers your question.
Yeah, no, it's true. You saw that everything is clear. Everything is clear. So to be careful. Yeah, even you meet the person for the first time, you should be careful. You need to use condom. But if it's the relation need to take more time, you have time to go to the consultation and see if something is true or false. I think it's clear. It's clear, Judy. Thank you.
Thank you. Yes, Luciana. You're muted.
I think I would like to add that it's always in my advice that I give to the people. I have to be responsible for myself, not another one. One day, I have to be responsible for myself, so I use condom. If it's a short time relationship when you have time to speak about when you started the treatment, whatever, that is another situation. But when it's occasional sex, there is not only HIV, there is syphilis, whatever. So it's better to protect yourself. You need to be responsible for yourself.
Thank you very much.
You're welcome.
Okay, so I spoke a little bit about PrEP, and maybe to just speak a little bit more, because I realize that slide is not on here. PrEP is a post-exposure prophylaxis medication that you get to prevent you, once you've been exposed to the HIV virus, to prevent you from contracting HIV. It rapidly kills the virus. It's a treatment taken for at least 28 days. And after that, it should have done its job of getting rid of the virus. Then you don't contract HIV and you're able to live HIV negative. Most cases, it is prescribed in medical settings, either in the hospital or sexual health clinics, but you can find out from your own countries where you would be able to access PrEP. So now we go to PrEP, and I'm going to try and run through a few things because we don't have a lot of time, and I really would like you to, one, live on time, but to have opportunity to also engage. So looking at the history, I'm looking at the history of prevention and how we've come a long way around PrEP. I know some of you really wanted to know more about PrEP in terms of what you wanted to get out of today's session, how you can integrate that into the work you're doing, how you can educate the communities about it. It's the new treatment option that we have. prevention option that we have. And we've come a long way, because at the beginning it used to be the ABCs, which was abstinence, faithfulness, and using condoms. But now we have other new ways of prevention. So in terms of looking again at the biomedical interventions that we had, as well as the behavior interventions that we had, and the social interventions that we had in terms of prevention strategies, we've done things around blood safety at the time when they made sure all blood is screened before you get blood transfusions. There was needle safety when there was immunization or any use of needles, and making sure it was a new needle used. There was voluntary male circumcision, again, to reduce the surface area and help with the stopping of contracting of HIV. There was treatment as prevention, where again, it's looking at being undetectable and not passing it on. But even for those on effective treatment, not being able to, if you, let's say, I've had conversations with some people who don't want to go to a hairdresser's, women who don't want to go to a hairdresser's, or men, a barber, because they feel if the barber is cutting someone's hair who has HIV and they cut them and they will get HIV. But understand that if someone is on treatment, they've contained the virus, they can't get it. Also, that HIV doesn't live outside the human body because it lives in a very controlled environment in terms of humidity, moisture, temperature. So once it's outside that environment, it doesn't survive, and most likely outside at a barber shop is not the environment for it to survive. On the blades of the clippers, it's not going to survive. So they shouldn't be worried that they'll contract HIV that way. And those are the questions we have in community, where people will not want to come and access services, or because of the stigma and misinformation they have. And then being able to diagnose other STIs, and that was an inroad to make sure you prevented from HIV, because most the correlation between STIs and HIV is very common. Then there was the post-exposure prophylaxis, and that was initially started with babies who were born of mothers who had HIV, who were then given that medication, and that is what has also created some of the foundation of the PrEP that we now know and are using. So that gives you a little bit of a background in terms of how we've come to where we are at today. So in terms of PrEP guidelines and what studies have been done, I just picked a few, and normally the few that I pick are ones that resonate with Black communities, but I can, if you would like some more studies that reflect other areas, please let me know. But the very first, and this shocks a lot of people, the very first study was in 1995 on animals, then followed by the first one in humans, and this was more, like I said earlier, out of PEP. When they were using that on infants, then they started PrEP on infants, and then the first adult study, well, that was terminated, was in Cambodia in 2004 because the results were not effective. Then the first one that showed significant results was in 2010, the IPREX study, which showed 44% effectiveness. And sorry, I've gone before that first study. There was a study done in Ghana with women, and that had 65% reduction in new infections, although that was not significant enough, but it was promising. And then the first significant study that had results of 44% effectiveness was in 2010. And that's sometimes to give people reassurance that there's been a lot of trials. It's a trusted drug, because again, in many communities, there's a mistrust around the effectiveness of PrEP. And this gives a bit of history in terms of what trials have been done and how effective it is. Sorry. So if I go on, these are some other more evidence in terms of studies that have been done with men and transgender men, then studies with the heterosexual men and women. There were other studies done with women with different regime delivery, and also there's a few studies that have been done with people who inject drugs, and you will get copies of these slides, but this is just to reassure the communities you're working with around the efficacy of PrEP. The most significant was the PROUD study. This was in the UK. That had 554 participants, over 13 sexual health clinics in England, where there was randomized PrEP usage of a 12-month period, and the deferred group offered PrEP ahead of schedule, and that gave us what we now know as the effectiveness of PrEP. And this is in the UK. This is what led to allowing for PrEP to be prescribed in sexual health clinics, and we're advocating for it to be prescribed even in other areas, settings outside of sexual health clinics, and some trials and tests, pilots are being done as well. I know in some of the countries in Europe, setting of PrEP is done in different settings. Some do it in primary care with your primary doctor, some do it in health settings, some do it in health checkpoints. So it's different different models in different countries. And in the session next week, we'll explore that a bit more. But what has been found from all the studies around PrEP is it is effective, it's approved, it's well tolerated, even in pregnancy, and can be used during together with contraception. So this is again around reassurance with community around PrEP and its efficacy and benefits as well. So we talked about breastfeeding earlier. So again, this is where it comes, that it is fine to breastfeed while you're on PrEP as well. So I know that you had a session last week around PrEP and what it does and how the dosage. So I'm not really going to spend a lot of time on this. If you do have any questions, let me know. But I think Steph did a good job in talking about this, and she's a clinician, so she will talk about it from a clinical perspective. I talk about it from a community perspective. I'm not going to talk about this because we are going to cover that next week, but maybe just to highlight that for some countries there's now long-acting PrEP in some countries, and this varies. We know there's some on the market that may not be available in Europe yet, but by yearly one injection every 6 months or twice a yearly injection is available now. The twice a month is also been approved in many European countries, and we know that some people are accessing this. Again, when we look at this from a migrant population, we can see the benefits of having long-acting PrEP as opposed to oral regimes because of the change in mobility, whether it's around confidentiality, safety, stigma. We see that again when we are talking about our communities benefiting from PrEP. Whilst oral PrEP is effective, they may even benefit more from things like long-acting PrEP. There's also in the pipeline monthly tablets, once a month tablet as PrEP that are also being trialed and in the pipeline. And there is a monthly vaginal ring. In I think Africa now they are introducing this, South Africa, but it hasn't come to Europe as yet, as far as I know. And these microsites where there's sprays and ointments that you can use, again, with the PrEP action in them. Yes, Jean-Paul.
Thank you, Jody. I want to ask two few questions. The first one is, actually, what is the future of microbicide? Because it's something that I know too much research has been done about microbicide, and since too long time now, they are not longer talk about it. And the second question is about PrEP by injection. So yesterday we was at a meeting here in Paris, and we was talking about the PrEP by injection and the other one, with as the tablet. So I think they let us know that there is a difference between PrEP on tablet with the PrEP injection, but I think it depends for anyone who is who think that injection is better for him. So, but what is the difference exactly? What is that different? Because then they say that the one with tablet is very hard in terms of prevention, but the one with injection uh, is okay, but not like tablet. What is your opinion about, Jody?
Okay, first of all, like I said, I'm not a clinician, so I'm talking from a community perspective, and what I so the scientific aspects of the difference I will not be able to answer. I can try and do some research and answer that question next week. But my understanding is the components of the tablet version vary. There are different components with different combinations. And for some people, for example, who have kidney issues, certain combinations of the PrEP makeup may not be recommended for them. So they are a different option, while the injectables at the moment are limited in terms of the combinations and therefore may not be suitable for certain people who have certain health issues. The other thing is, whilst oral tablets are cumbersome in taking, they also leave your body faster. So if you forget to take the oral tablet, your chances of putting yourself at risk are greater. While with the injectables, because they are long acting, they prevent you longer. That's what I know. Unless somebody in the on the call can give a better explanation, at the moment I can't answer any better than that.
It's okay, Jody. It's okay. No,
And
so
the microsites, I think it's around efficacy at the moment. That's why we are not hearing a lot. So the long acting have come, and the efficacy is a lot better than the microsites. So, but I also agree that we need to hear more. And like I said earlier, for me, it's around choice. If we can get to a place where someone has choice, and the choice can also be interchanged. So we'll talk a bit about that in the next session. I think that's where we should go to, the idea that you can choose between long-acting part when you're in a transitional period, you don't know where you're settled, you haven't got a fixed home, you don't know whether you'll still be in this area of the country, then long-acting injections may work. Then eventually you may be settled, and now you don't want to have the long-acting because you want PrEP for a shorter period of time. Then that's what you use if you're in a long-distance relationship and you don't want to have something in your body for a long period, then you use the oral tablets. So I think that interchanging should also be part of where we're looking at PrEP and how it works for different communities.
PrEP injectable is not ready at the moment in France because the laboratory, Gilead, is trying to work with the government to see how the price can be accessible to the population. I think the price is very high at the moment.
Yeah, for many countries, yes. Hala?
Yeah, Judy, thank you. I want just to reply to John that last session with Stephanie, she explained this very, very, very properly, the differences between PrEP and long-acting injection. And we will share this in our website along with her, the recording, her presentation, and some documents. And you can like check it to understand this more. Thank you.
Thank you so much. I'm glad there is an answer for that. Thank you. So we talked about in the beginning, many of you were talking about challenges you face in terms of getting your communities engaged or understanding the benefits of PrEP. And what we don't have enough time because I think I'd wanted to have a discussion around this, but looking at practical strategies, and if I can remember some of the strategies, a number of you had mobile vans or mobile units that you took out, and that's where you did the testing and interventions around condoms or referral into other treatment centers. But through that, you're able to have, and I've called it clear counseling, although what I mean is conversations with people, whether it's pre-testing conversations to understand their vulnerabilities and risks, to understand their behaviors and choices, to understand other issues around their choice making that influence their choices, and having that conversation. And I think what the benefits of community settings like the ones you are working in is you have that time where you have peer navigators or ambassadors or people who look like the people you are supporting. They're able to empathize and understand what the challenges are and help around building confidence around what strategy they use, whether it's now PrEP, how do they benefit from that, how do they access it. Then in terms of adherence, which is equally important, because again, there've been a number of, especially young MSM Black who have then seroconverted to HIV because their adherence wasn't good. So it's really important to educate the community, to educate who you're talking to. That adherence is very, very important. If you don't adhere, you don't have enough cover, and then you can acquire HIV. So it's understanding what strategies can they use to remember to take their medication. Is it around take it every morning when you brush your teeth? Or if you're doing event dose, how do you put reminders to make sure you remember when you're taking it? And also provide the follow-up or ongoing support. So I know that Anna mentioned that when they go to these community settings or churches or drug and alcohol settings, eventually they're even called back on a regular basis. So it's how do you build in that kind of ongoing follow-up with these communities that you're working with? So if there are people that you know have gone on to PrEP, you make sure you're supporting them through that to make sure they are adhering, you're following up, and if there are any needs that come up, you're able to support them through that. Where there's refill systems, how does that work? It's looking at cross-border. If someone is moving from one country to another, one area to another, how do you coordinate that where possible? Or how do you facilitate that, I think, where possible? And I think having a network like this one that mHealth has, where you're in different countries, you're able to support people. If you know someone tells you, now I'm moving on to this country, you're able to say, I can make a connection for you here, you can get support here. So that is quite helpful, so people don't drop off the system. And then most important is around addressing myths, addressing misinformation, addressing stigma and the cultural concerns. And I think this is something we talked about in the beginning when you are all sharing what to do and the challenges you face, but making sure that it's really important to have services that are culturally sensitive to the community you're serving, have people that look like them, or if that's not possible, educate yourself so you really understand the culture nuances in many of the communities. It's not about using Google Translate to translate information. The tone, the language also really matters in how people respond to the information you're giving them. So it's also being aware of some of those things. And we'll talk a lot more about that in the next session that we're doing next 2 weeks, I think, away. But making sure that there's continued care within your mobile communities. And I like that most of you were going to these communities, but make sure that that's continued. I know there are problems around funding and how, and with the US and what happened. I know that that's caused a lot of problems. I know somebody spoke from Rwanda around the issues they're facing around access to treatment and what, but how do we make sure that there's continued care within that, especially for mobile communities? How do we follow up? I know that in France there is, I forget, she was in the previous My Health training, but they run a sex worker mobile van that goes out every night, and that means they're able to go continuously to the community, work with the sex workers, provide PrEP or condoms or treatment or whatever they needed. Contraception was all done on site there continuously, so that it was the sex workers were able to continue their work and do it safely without having to take out time to come to clinic to access treatment. Yes, and you've put your hand up, but I don't know what your name is. I see ISIP. Kim. Thank you, Kim. Yes, go ahead.
First.
Yes, go ahead.
Yes, actually I didn't introduce myself. Do you hear me? Hello?
Hello.
Do you hear me?
Yes, we can hear you.
Okay. Actually, I didn't introduce myself. My name, I'm Kim. I work for the Association for the Community LGBT. Dominantly, we work for the trans sex workers and people living with HIV. Yes, we are the one who's doing this project.
Oh, thank you. I remember you, Kim.
Yeah, basically we do prevention almost every night. We with our prevention bus. We go in some areas where you can find sex workers, and during the preventions we have the chance to talk with the girls, from health to administrative, aside from distributing condom, aside from talking about sexual health, aside from what we call this proposing HIV, hepatitis B, and hepatitis C testing. We also introduce, or we also ask them to do the consultation for PrEP, because in our association we do consultation PrEP 2 times a month. Actually, we were the first association in Paris who do the PrEP consultations. I started in September 2017 until today.
I am so happy that you're on the call, and it's good that you've shared your piece, your work, because you do great work. And I'll try and make sure the next session I give you a bit more time to talk about your work, because that would be a good case study.
Thank you so much. I'm just here listening.
Thank you. Thank you. So we talked, and I know we've gone about 4 minutes over. I'm just asking if we can have another 6 minutes to finish at 10 past. I'm really sorry we've taken a bit long. So again, we talked about some of these earlier in terms of what are the barriers that migrant communities face around being a mobile community, not having a fixed address or fixed stay base. In certain countries, again, being housing situations are dire, and that uncertainty causes huge problems, documentation or lack of, and what that means in terms of access to health services really creates a problem for many of the migrant populations, where healthcare is not free. What happens when a woman gets pregnant and she has to then give birth or have access maternity care? I think there was a case study that was shared where this lady initially accessed the healthcare because she was expecting unwanted maternity care, but through that they realized she was also HIV positive. And sometimes while accessing treatment for HIV is free, things around maternal health care are not free. And how do you negotiate those kind of things? So it's those kind of challenges, and that can become a hindrance for people to come forward. The fear of authorities, a lot of community countries now have got very hostile policies around immigration or immigrants. So how this causes fears and people go underground, and then instability as well, and all these issues that really affect adherence and continuity of care. So it's important to be aware of those. And then again, maybe just around the managing, and I know that Steph talked about side effects, and what we know is there are very few side effects in terms of PrEP, but then things around continuous testing to make sure that they have not contracted HIV. In some countries, it is every 3 months. For some people who have been on PrEP for a long period of time, they can increase it to every 6 months. If their adherence is good, then they make sure that they just have their tests every 6 months. And also continuous STI screening is very important as well, so that whatever is contracted can be treated as soon as possible. The renal function check is also good, and also making sure that adherence is discussed and is maintained, because without maintaining the adherence, someone can seroconvert to HIV. So that's really key. And that can be done with your continuous ongoing involvement with the communities as well. So that's, again, what I talked about, the regular testing, and confidentiality plays a huge role because there's a lot of fear. I gave the example of the case I'm working with, but even migrants not knowing what their rights are. So it's really important that we understand these challenges and the importance of trying to support my migrant communities to overcome these challenges, so that they can then access care and engage in better health behavior. This is just a principle, and again, you get these slides, but the principle for effective PrEP program implementation, and it's really around ensuring that you have cross sector stakeholder engagement, and this is whether you're working with if it's a person in drug and alcohol system, or it's someone who engages in a misuse of drugs, or if they're in work or illicit behaviors because of a source of income. How are you engaging whether it is, for example, are you engaging housing? Are you engaging organizations that specialize in drug and alcohol, organizations that specialize in supporting sex workers? So you get all the different stakeholders on board is very important. And if it's faith leaders, those are stakeholders as well. Making sure you create a stigma-free environment so people feel welcome and feel it's a safe place for them to be honest about their behavior, so that they can get the best outcome out of prevention. Making sure that it's based on the population that you're serving, looking at the combination of HIV and STI prevention, really highlighting PrEP will only protect someone from HIV and not STIs. Creating awareness that resonates with the community that you're trying to work with, and not necessarily standard materials, because that may not resonate with the community you're working with. How do you work in collaboration with the guidelines that you have from your local authorities, clinical and public health guidelines, standardizing eligibility criteria? This has been a huge problem in many countries. The UK has formally just updated theirs, where now PrEP is okay for, I mean, is free and accessible for anybody who needs it. But in some other countries, I know it is for particular communities, and that means certain others are left out, or particular people with different vulnerabilities, but that means some other people are left out. So really revisiting that. Also important is linkage into care, making sure that once they're linked into care, they continue on treatment. So adhering and continuing on PrEP is important. And you can only do that if you're monitoring and evaluating. So that's a framework that is really helpful to make sure that you have entry points through all those checkpoints, and it gives you a rounded program, PrEP program service. So I had these, but I will hold on to these. These are just different areas where PrEP is coverage and instances, and activists that are working around PrEP advocacy in different countries. And I will share these later. These are resources around PrEP programs, and I'll visit these the next time we meet and talk around different case studies of programs that are happening in different areas around PrEP. This will help those who say they wanted to have ideas of what to do, how to engage, know what others are doing. But can I also ask when we come the next time, if you can at least give, if you're already doing something around PrEP in your organization, come with a little, at least 1 minute of what you're doing and how you're doing that. And that becomes a skills sharing for everybody. So I know we've run out of time. I wrote down what most of you said you wanted to learn from the session. I'm going to go back to it and review it. And if anything hasn't been covered, I will make sure I include it in the beginning of the next session. But if there is something that you feel I haven't covered and you urgently would like me to cover, if you can either email Hala or myself, I think they will share my email, and I can make sure I incorporate that in the next session. The next session, we are going to cover more around, I'm just trying to get it up. We're going to cover more around the barriers to PrEP, stigma, around social, economic issues, structure and legal, and how these influence, looking at the cultural beliefs, power, gender dynamics, religion, religious beliefs, medical mistrust, and all those kind of aspects that affect uptake. So we're going to focus on that next. I think it's the 2nd of December, I think. And there will be an evaluation after you've had all the sessions, just to see your feedback and see how we can improve this. So that is it from me today. Unless there is any burning question, I would like to thank you so much for your time. And sorry again for going overboard.
Good evening, everybody.
Thank you.
See you next week.
Thank you so much. So, thank you again for joining us today, and especially thank you for Judy for sharing your expertise. And for more information and to explore previous trainings, please visit our website. And we would love to see you next week, where we'll be discussing your personal topic with Judy. And thank you. Have a very lovely evening.